Good evening, everybody, and thank you for inviting me to this wonderful conference. We had a great time this morning reviewing cases. My topic tonight is how to monitor the progression of CTCL. That's a tough question. So these are my disclosures. Now, we have just heard a wonderful presentation from Dr. Julia about the classification of cutaneous lymphomas. As you know, this is not one disease. There are multiple diseases, and tonight we're focusing on mycosis fungoides. But we have to remember that cutaneous lymphomas come in many flavors and many types of presentations. So this is one of the biggest challenges. The presentation is so variable at the time of diagnosis or as the disease progresses. How do you monitor these patients? How do you know that the disease is progressing? And that remains a challenging question. Here you can see the multiple examples of skin involvement, blood, and of course the systemic and nodal involvement. So this disease primarily involves skin, blood, and lymph node, and in rare cases, the viscera. I'm not going to go over the classification because we just heard a great review from Dr. Julia, so I'll skip this slide. Basically, the whole point of this slide was to show this complicated staging system, which, to be honest, even after years of practicing, I don't always remember. But I do remember that if you have, you look at the skin, you see how involved it is, the percentage of body surface area, patches, plaques, type of skin lesions, whether they're tumors, whether there's erythroderma present. So that determines the skin stage. And then you feel for lymph nodes or look for adenopathy, and that determines the end stage. And then the blood involvement is very important, which can be seen even in early stage disease. And then you put the whole thing together and you come with the stage, and then you kind of go from there. And remember, staging is always done at the time of diagnosis, but then later on, as the disease progresses, we do restage the patients, but we have to clarify that it's at that time that we're dealing with the stage. I just wanted to also point out a few things. Clonality assessment in cutaneous T-cell lymphomas is important. We've learned a lot from the histology. We've learned a lot from looking at lesions under the microscope, but sometimes it becomes difficult to distinguish between inflammatory conditions and actual true cutaneous lymphomas, particularly early stage disease. And this is where clonality helps. You can do it by TCR. You can look at the TCR gene rearrangements and either use PCR methodologies, either Biomed2 or other standardized approaches to really establish the clone that's present in that lesion. That can help us not only in diagnosis, but also in following the progression of the disease, as I'll show you in the later slides. And then you can also use now high throughput sequencing to further sort of clarify the clonality. And it can be performed both on skin samples, paraffin embedded, and in peripheral blood and bone marrow as well, if you've done a bone marrow. But the important thing to understand is that the skin clones should match the blood clones if to really establish clonality. Or if you have two different skin lesions, as Julia had mentioned, you want the clones to be the same. So it's important to sort of, if you have the technology available, to try to establish that as part of your staging workup. Okay, so now we've heard about the MSWAT. You all are familiar with it. Just to kind of remind you, this is how you look at the skin. You kind of have to, this is a disease which is very visible. So to follow it or to see the progression, all you have to do is examine the patient. And to kind of quantify it, which we sometimes need to do in terms of clinical trials or even in clinical work, we use the MSWAT. I'm sure you're all familiar with this. You take the patient's palm. This is 1% of the body surface area. The body is divided into different parts. As you can see in these diagrams, you can get these online or apps, and et cetera. You decide if the patient has a patch, plaque, or tumor. You give it a certain weight, and you add it up, and you get a score. Fortunately, we have fellows who do this for us, so we don't always have to do it ourselves. But the MSWAT score is one way to see if the skin is getting worse, particularly if even if the surface area is not changed, but the lesion has changed its character. It's now patched to, from patch to plaque or tumor. The MSWAT will increase, and that'll help you determine the progression of the disease, especially if you're doing, as I mentioned, clinical trials. There's another SLAT score. I'm not very familiar with this as a hematologist, but I think dermatologists use this a lot. And it's usually helpful for non-MF type of skin lesions. It's basically the same idea as an MSWAT, but you don't use the body surface area. You just take the actual lesions, in various parts of the body, and then again give them different weights based on whether it's a patch, plaque, or tumor, add it up and come with a score. There's something called the Kale score, which is used for index lesions, again, to monitor local treatment. So, we talk a lot about skin-directed therapies, but how do you know if they're working or not, especially in a clinical trial? So you actually have to look at the lesion. You can take up to 5 index lesions. These guidelines were published 2 years ago for clinical trials, but they're also useful in clinical work. You can look at the properties of the lesions, and I'm sure you're all familiar with describing skin lesions, whether the color, the scaling, et cetera. Size, the longest and the shortest diameter. I usually walk around with a little scale in my pocket, and then you add it up, and then you can follow it. Lymph node assessment becomes complicated. There's always the physical, histologically becomes complicated, but physically it's pretty easy. You do a physical exam, you can feel for lymph nodes, and anything that's at least 15 millimeters in size is considered abnormal, whether it's by physical exam or by scan. You can do CT scans, you can do FDG PETs with or without dedicated CT, you can do an MRI, ultrasound, whatever is available to assess the size and location of the lymph nodes. You need to confirm for N3 disease, you need to confirm lymph node involvement. And nowadays we do a lot of core biopsies. You can do an excision biopsy as well. Just don't do an FNA. That's just not enough. And then currently for lymph node evaluation, we use Lugano criteria, which is based on PET criteria. There's also the CT response criteria. And on the right side, I've just shown you some of the, the Lugano criteria for evaluating PET scans. And here's an example of a patient before and after treatment. So that's helpful if you have lymph node involvement. And same thing goes for visceral involvement. And blood, I'm sorry, I think we've missed a few slides here. Oh, sorry. I think I need to go back. I always do this. All right, so lymph node assessment. So the next thing is to look at responses in the skin. These are, so how do you know if the patient's actually, how do you define response? So obviously our goal is a complete remission where you want 100% clearance of the skin. What about partial responses? So partial responses are determined by, again, this is more useful when you're doing clinical trial work, but when you have a baseline and then now you have a 50 to or less than 100% clearance of the skin burden from your baseline, but there's no advancement in the stage of the disease, meaning the lesions haven't changed in their character. And there's such a thing now we call very good PR. This has been borrowed from multiple myeloma, the VGPR, where it's like a 90 to 100% clearing of the total body involvement, and there's no progression. Stable disease is, sort of falls in between, which is less than 25% increase or less than 50% clearance of the skin. And then progressive disease is going to be if you have more than 25% increase in skin disease from baseline, or loss of response in the patients who either had a CR or PR. And then there's a complicated way to determine a score from the baseline and nadir. So this is kind of how you look at skin, and if you're trying to describe it in a paper or clinical trial, that's how you would do it. Responses in blood are important. So again, if you have blood involvement, your goal is to get down to B0, which is less than 250 international units per microliter. A PR is more than 50% decrease in your quantitative measurement. Stable disease is if you don't get a CR or a PR, and then progression is if B0 goes to B2, or if there's more than 50% increase from the baseline. And again, you can find these in the literature, but you have to count the cells. That's the important point. So, if it's not just enough to say there's blood involvement, you've got to actually count the cells. And again, you look for CD4 positive, CD26 negative, or CD7 negative cells. And then there's, at least at our center, we actually have to do it manually. So we have to know the total lymphocyte count and multiply the percentage of these abnormal cells to get an absolute number. And here I've shown a clinical example of how one of my patients, how I actually calculated the absolute number. I got the CBC that day and a flow cytometry, and the absolute number of abnormal cells was 58%. Out of 1.2 was the total lymphocyte count, so we came to 696 cells, so this was a B1 patient. So then you can follow that serially to see what's happening to the blood compartment. This is the triple society, ISCL, USCLC, EORTC global response criteria, where you put all of this together. So this is not an easy disease to follow, as you can see. The staging is complicated, and then you look at all these compartments, and then you put them together into CR, PR, stable disease, or progressive disease. The important point to remember is that the response is determined primarily by the skin. So if the skin is not responding, you can't call it a response. So you have to have skin response, and then you have to look at the node and viscera and make sure that those compartments are not progressing if you are calling it either a PR or a CR. And any progression in this disease stage, or especially in the skin, is progression. So there are some issues with assessing the skin response. So as I mentioned, responses in CTCL are driven by skin clinical exam, and that's the most important thing to remember. So how do you follow that? I've talked about MSWATs and all that, but really, serial photographs can be very helpful. And we all have cameras in our phones now, but it's important to make sure that you kind of make the photographs uniform, similar background, and try to make them, hopefully the same person takes them serially. One thing to remember is that healed skin can look hypo or hyperpigmented. And as a non-dermatologist, of course, I get confused by that. You guys go ahead and say, oh, this is just, you give it fancy names. But really, it's important to know that sometimes, especially in patients with pigmentation, that the lesions will, skin is not going to normalize even when it's healed up. So it's important to remember that. And remember, flare is another problem. So with a lot of treatments, you can have inflammation. And remember, this disease is outside the body. You can see it. So when there is inflammation as a response to treatment, it may look worse. So, and you may call it progression, but you've got to remember the issue of flare and keep that in mind. And on top of it, the lesions in the skin can even on their own wax and wane. We've seen that, skin clears because the weather changes or they have some exposure to sunlight. So in order for a response to persist, we do recommend, the importance is that the response must persist for at least 4 weeks. And then if you're in doubt, you should always perform a biopsy, particularly if you're not sure if it's a flare or an inflammation. On the right side, I've shown you some examples of what looks like flare in response to treatment. And at the bottom, there's a picture of progression in the same lesion, which is now starting to look more like tumor. So it's important to understand that and keep that in mind before we call somebody that they're progressing. Now, the question that was put to me, how often do you do imaging studies? How often should you be following these patients? So there's really no clear guidance. It's at least from the societies and even NCCN. In terms of imaging studies, as I mentioned, there's several ways to assess lymph nodes. Most common is CT or a PET CT. Important thing to remember, get a whole body PET, not the eyes to thighs, because if you have lesions on your arms and legs, you're going to miss that. MRI ultrasound is another option. Baseline, the recommendation is to do for stage 2 and beyond, or if you have palpable adenopathy. I usually don't do it for stage 1A disease, but I may do it in selected cases of 1B. This is the baseline scan. Restaging, again, no set timing for follow-up, only as clinically indicated. How do you know if there's progression of skin lesions, especially if the patient is now starting to develop thick plaques or tumors? You may want to get a scan. You start to develop new adenopathy. The patient tells you, I have a bump here or there, or you do that on your clinical exam. If the patient becomes erythrodermic, or they start to have more itching for some reason and you're concerned that they may be erythrodermic. When you're starting systemic therapy, I usually get a scan because that's how I'm going to follow their nodal or visceral disease if it's that suspected. Obviously, you need to do scans to confirm responses to systemic therapies, especially immunotherapies, or if you're using chemotherapy. I usually restage with scans every 4 to 6 cycles when they're getting systemic therapies. And if you're doing clinical trials, they will define, usually it's after every 2 cycles, but you don't have to do that in practice, particularly if the patient's responding. And if they achieve remission, I don't have a set, I don't do scans every 3 months or 6 months. I just follow them clinically. I do that for systemic lymphomas as well. I may do a scan once a year if I have a high suspicion of relapse, but really there's no clear guidance on that. You also don't want to scan the patients too often. Blood involvement, again, peripheral blood for evaluation, you need to do CBC flow, clonality studies. I always do it at baseline, at diagnosis, even in stage 1A, and at follow-up when I suspect progression. How do I know that? Again, worsening skin lesions, new onset of erythroderma, change in stage of the patient, itching, particularly if they have intractable itching, I always check the blood, and also to document responses at the end of therapy. I don't recommend doing bone marrow biopsies. They're rarely indicated, only if they have abnormal blood counts. Even in B2 disease, it's not recommended that we do a bone marrow biopsy. It's not helpful. But yeah, if you suspect systemic involvement, like visceral involvement, if they have abnormal blood counts, and I also do it before stem cell transplant to document mostly that they don't have MDS or an MDS-like picture. Minimal residual disease. So I thought I'd show a few slides on that. This is kind of emerging as a new concept in CTCL because we are behind in our treatment of patients with mycosis fungoides and CTCL compared to B-cell lymphomas and other diseases, myeloma, for example. So we have methods to look for microscopic and molecular disease by PCR and sequencing. And we can do it in blood as well as skin. So we can try to use this in the form of, to document complete response, complete molecular response, and see if there's any residual disease left. We don't know if it correlates with response. We think it might, but the biggest question is, can it predict relapse in a patient that has achieved a remission? And in which compartment? Should it be skin? Should it be blood? So these are some of the questions. So the background of minimal residual disease is that you're basically looking for clonality. So as the T-cell malignancy develops, you lose the polyclonal TCR repertoire, at least in the lesions, and you start to emerge either oligoclonal cells or a clonal, or one or two clones will emerge, which will be in the skin or the blood or whatever tissue is involved. And as you know, TCR is a sort of a heterodimer. It has two polypeptides, the alpha, beta, or gamma delta chains. So the malignant cell clone will have either alpha, beta, or a gamma delta subtype, mostly alpha, beta for mycosis fungoides. And then you can look for clonality by looking at these peaks in TCR arrangements. So with this background, there's a couple of papers that have been published. This came out of Stanford, and they're transplant patients, and they have done PCR for T-cell receptor clonality, and then they followed that by high-throughput sequencing, identifying malignant clones. And they actually did that before transplant and then after transplant. And on the right, it's kind of a busy slide, but if you go to the paper, you will see these patients' examples where after the transplant, for example, here, after the transplant, as the immunosuppression decreases, they can actually document minimal residual disease. They cannot detect the clone in the blood and the blood anymore. And they can follow this, and their goal was eventually to see if they could predict relapse or not. But these are just examples of how they're starting to use these studies in clinical work. NGS clone sequence assay, this is another methodology. Again, it actually improves the sensitivity of clonal detection as compared to PCR and NGS. So it's helpful to do that if you have the technology available. At City of Hope, we've looked at about 250 patients and looked at TCR gene distribution in skin biopsies. These are 82 patients. There's another publication that's coming out with the rest of them. And this is with and without large cell transformation. And you can see the documentation of these different clones in different stages of the disease. And so the idea is that with this, we can start to pick out patients who will eventually develop some kind of clonal emergence. And then maybe we can predict responses in that way. And lastly, I'll just show you an example of how we're using sort of this MRD to determine treatment and response. And this is an actual patient of mine who was treated, had Sézary syndrome. On top, you can see his clones in the blood and skin on the top left, your left box. This was in May. Treatment was started with the specific therapy, mogamulizumab. And in the middle, you can see he had achieved a CR, and the clone had disappeared. And then he developed a new rash a few months later. When we did the biopsy and did the clonal sequencing, it was a different clone. And so we decided that this was a flare, an inflammatory response. Treatment was discontinued rather than escalated. So this technology is probably going to be helpful in following these patients. And in conclusion, I just want to say that we know CTCL is a heterogeneous disease. You need to assess disease response in all the disease compartments that are involved and then put the whole thing together, but mostly the responses are driven by skin responses. Beware of flare and treatment-related inflammation and not call it progression. Skin biopsies are a good way to determine the difference. And then you have all these new molecular techniques that will probably help us understand disease and monitor responses a little bit better. And with this, I want to just end here and thank you. This is our MAG campus. And on the right side, this is the celebration of life. We have this every year for our bone marrow transplant survivors. This is not CTCL only. These are all transplant survivors because we are a big transplant center, and our family is growing, so it's just good. Thank you.